Hello, everyone. Welcome to this evening's event. Before we start, I need to confirm if everyone who's joined so far can hear me. So just put a note into the chat box if you can see and you can hear me speaking. Hello, everyone. Can anybody hear me? I can see that we have some people who have joined this evening's event. So just put a note in the chat box if you can hear me so we can start. All right, we'll just okay. All right, let's go. So welcome this evening to this event. Kendi Oloriade, and I'm the team lead for Radiology Interest Group Africa. It's my pleasure to welcome you on this platform today. So this is an interest group for African medical professionals who have an interest in doing radiology as a specialty. It's open to medical students, junior doctors, those who are in training, and even consultants who are interested in specialty. We hope to support each other in our career aspirations and help open up the opportunities if people have interest in collaborating internationally. Also, we're also trying to create a bank of resources where people can go to if they have interest in exploring topical issues in the specialty. A lot of us here are familiar with the concept of the clinical audits, especially if we are probably applied to jobs in the NHS or working in the NHS. We've come across it as a quality improvement program or project that sort of compares clinical practice in our different centers with national guidelines like the NICE guidelines. The speaker today is Dr. Igwe. He's a second-year radiology specialty registrar at the All University Teaching Hospital. And earlier today, we're having a chat about how he took the scenic route into radiology and how he's enjoying it now. And I'm sure there are a number of us who are looking to apply into the specialty training maybe this year and the next 2 years. I'm sure we can pick one or two things about how to do audits, which we can include in our portfolio, or even if we have the opportunity to present internationally at conferences and also in publications. Just as a rough idea of the agenda of today's program, after this introduction, the speaker is going to come give us a presentation. If we have questions during the presentation, just make sure you put them into the chat box as they come up. After the presentation, we'll give opportunities for interactive session with the speaker, where he can engage and answer as many questions as we were able to cover. Following the answer questions, the question and answer session, we're going to have the a short announcement from our educational lead about the research bootcamp we are organizing as part of our programs this year to help people engage in radiology research. This will be open to our members, but she'll be able to give more details as this goes on. We would also like and appreciate your engagement with feedback from this event, so we can we can improve on future events, and yeah, just get to know more about your pinpoints or things you would want to learn from this interest group. So shortly, I'll be leaving the stage so the speaker can come in and present and make the presentation. Hello, Dr. Igwe.
Oh, hi, Kane. Thank you for the introduction. Good
Yeah.
evening, everyone. I'm just going to try and share my screen, and I hope everyone can hear me. And Kane, can you just give me feedback if everyone is hearing me and if they're happy for me to proceed?
I can hear you loud and clear. So,
Perfect. I'll just share my screen. Have the slides come up now?
yes, can see them.
Okay. Yeah. Good evening, everyone. Thank you for the introduction, Kane. Like I told him earlier, I serendipitously stumbled upon radiology. When I came to the UK initially, I planned to do medicine and wanted to be a cardiologist or an oncologist, but things happened in between, and I decided to do radiology instead. And like you said, I'm not regretting it at all. In fact, I'm actually really enjoying it. He asked me to present this topic, which is conducting a good clinical audit in radiology, which is a very important topic in healthcare in general, really, not just radiology. Again, I'll just do a very short presentation over the next half an hour, and then you guys can ask me questions, and we can be able to obviously talk more about portfolio building, radiology, or just specialty training in the UK generally, and we can take it from there. What we are learning objectives today, essentially we'll be looking at what are essentially the purpose and benefits of radiology clinical audits. Why are we doing it? Why is it important? And how does it actually benefit patients? And most importantly, how is it necessary or important for your CV? Because essentially that's why all of us are here, isn't it? And again, we want to know the key steps involved in conducting an audit. We want to know the types of audits that are available in radiology. We want to know what are the best practices and what are the potential challenges in conducting an audit, whether you're in the NHS, you're working in the UK, but you're not in the NHS, or whether you're overseas, maybe you're in Nigeria, you're in other countries as well. And then obviously just look at some case studies and some examples from my own personal experience, from colleagues, and obviously from the internet as well. I tend to describe radiology, the role of radiology in healthcare generally as a lighthouse. So obviously you can look at the lighthouse, you can look at the waves of the sea, and you can look at the ship. I think I describe it as a radiologist can be compared to a lighthouse. Is guiding and overseeing the safe passage of ships, and essentially, the ship is the patient, and the vast ocean that you're seeing is sort of the current healthcare that we have at the minute, because healthcare is very turbulent, it's very complex, it's very difficult, and to navigate. So radiology sort of provides those critical information that would help the patient safely navigate through healthcare. And how does that relate to clinical audit? In the context of clinical audit, the lighthouse symbolizes the radiologist's vital role in maintaining and improving the quality of care. So just as the lighthouse obviously, must be regularly maintained and updated to serve its purpose effectively, radiologists must also participate in clinical audits to ensure their practice remains up to date, their practice is efficient and is obviously in line with established standards as well. So essentially the clinical audit process will help to identify areas of improvement, and audit is essentially one of the backbones of clinical radiology. And radiologists are at the forefront of clinical audit in healthcare. How does this relate to portfolio building? Because essentially, if you're trying to apply for a specialty, either you're applying for radiology or you're applying for any other specialty, you have to build up your portfolio. And unfortunately, it is difficult and very important as well. But the most important thing I always tell people is that you have to look at the portfolio scoring criteria. You have to have this sort of made up table about this portfolio scoring criteria somewhere, in your bed or your living room, anywhere. And you have to make sure that you sort of highlight those key areas and ask yourself, how can I score those maximum points? And essentially, these are not questions you'll be asking yourself 2 or 3 months before the application process open. These are things that you should be asking yourself, a year or 2 down the line before you want to apply, because you want to give yourself enough time to be able to get as much maximum points as possible. However, from my own experience, I decided to apply for radiology a week before the application closed. And I managed to get some points. So I suppose if you're already applying certain principles, such as if you're already doing audits or some form of quality improvement, or if you've had some previous academic achievements or some previous prizes and awards, or you're already in teaching, you're probably scoring some points. But the earlier you sort of tease out those important things that they need, the more you can actually make out those maximum points. I think this was last year's portfolio scoring criteria for this year's incoming ST1s. And if you look, it's very difficult for you to score some of these top marks. I'll just highlight the one for audit and quality improvement because that's what we're talking about today. But it carries about 7 points if you get the maximum points. And what does it take for you to get the maximum points? You have to have led 2 or more audits that is related to radiology, and I've shown that these have changed practice. So 7 points is a lot of points. So audit is important in terms of your portfolio. So unfortunately, you have to do them at the end of the day. Again, people are going to ask, this is difficult. I'm not sure I can be able to do this. But actually, if you look into the nitty-gritty, it's not as difficult, as people make it out to be. Leading a project doesn't mean that you have to do everything. Essentially, it means someone that's played a major role. Either you've played a major role in conception, either you've played a major role in data collection, either you've played a major role in data analysis, or if someone did these things and asked you to present it, that's essentially you leading a project. Have you changed practice? It doesn't necessarily mean that you've done something big and the chief executive of the hospital have actually spoken to you about it. Essentially, changing practice simply means that there's been a difference. Okay, if something increases from 70 to 90%, that's a change in practice. If something leads to better compliance in one way or another, that's a change in practice. And related to radiology simply means that, honestly, anecdotally, I think 60 to 70% of audits are in some way related to radiology, because people are going to talk about investigations, people are going to talk about processes. Most of these have some form, inclination to radiology. So, the long and short of it is you can score the maximum points in audit and quality improvement, but then it requires a bit of time. And then the maximum points you score in quality audit and quality improvement can equally help you score reasonably good points when you obviously go on to prizes and awards, because you can obviously present those awards in radiology meeting, and obviously you might be able to score some of those 6 points as well. So essentially, doing well in audits and quality improvement can earn you maximum points in sort of 2 out of 7 domains. So yes, it's very important, and I think you should sort of, and it's good that obviously everyone is here to sort of learn a bit more about audits. Again, what's clinical audit and why are we doing it? And then clinical audit stems from quality improvement in healthcare, which is essentially a systematic use of methods to improve quality of care which we provide to patients, and obviously ultimately improve patient outcomes. And again, people obviously confuse the outcome of what is a QI and what is a clinical audit. Essentially, I think they are similar. However, clinical audit is sort of an initiative or an essential component of the broader concept of quality improvement, and it gives us a good insight of what current practices is like. It measures effectiveness against an agreed or proven standards for high quality, because essentially this is where people miss what is an audit and what is a clinical research. And as we'll talk about in types of audits, sometimes people confuse a retrospective audit with a retrospective study, which is essentially a clinical research. An audit needs to have an agreed or proven standard for high quality. There should be a bar that people should, or an institution or a group of people need to obviously be aspiring to, in terms of the process of healthcare delivery, the outcome for patients. And obviously, whatever you're doing is that you're measuring whether these standards are being met, essentially, and then you're finding ways for you to be able to improve them. Again, the initial problems I had initially was I find it very difficult to differentiate between clinical research and audit, which essentially meant that I spent time designing the clinical research instead of just doing a simple audit. And I know a lot of people were saying that they didn't understand data analysis and all that. I think if you're talking about data analysis, you're almost certainly going into clinical research. An audit doesn't require you to download SPSS or the big softwares to do analysis. An audit simply requires actually a calculator or an Excel sheet. That's it. And you can get an audit done. So if you keep thinking about it as something big or like a big research project, then obviously you're setting yourself up for for a bit of a disappointment, because you need to be able to make it very simple. That's the way you can be able to deliver it. Okay. And again, this is just leading up to the 6-dimension quality framework, because obviously, like I said, audit essentially tries to measure and ensure that this quality framework is being followed in healthcare. So how do you do an audit? What's the audit cycle like? You want to first of all identify that there's a problem. And then if you identify there's a problem, then you have to come up with methods to be able to address the problem. And for you to identify a problem, you need to know that something is a problem if there are certain standards that have been set to address that problem. So essentially, if you're doing a clinical audit, you're not coming up with anything new. If you're coming up with something new, that's a research. So clinical audit means that someone has studied something, or someone has obviously established a certain standards and said that this is the standards that we should be meeting for something in healthcare. And essentially what you're trying to do is to find a way to measure and see whether either in the institution that you're working, either in the ward that you're working, either if you're working in theaters or if you're working in the lab, or anywhere you're working, you want to be able to identify whether you or your team are actually meeting those standards. Obviously, when you identify that, then obviously you can talk about the methods. Then obviously you can go on to analyze what you found and comparing it to the standards. And then you can obviously think about an action plan on how you can instigate some changes. And then you need to do a bit of monitoring, and then you can do another re-audit so that you can be able to close the loop. And essentially, this is a very nice summary from RCGP that obviously sort of set up the entire journey to do a clinical audit. Obviously, you can't do an audit without choosing a topic, but like I'll come to in a minute, choosing a topic is one thing. I think the most important step in doing a clinical audit is finding a suitable supervisor or a mentor or someone that can be able to guide you through the steps. Once you're able to do that, then you can choose a topic, then you can set a standard, then you can collect your data, then you can analyze your data, then you can implement some changes. And obviously, when you implement change, you need to give it a bit of time. So giving change time can mean 1 week, 1 month, 2 years, 3 years. So you need to be able to, when you're selecting an audit topic, you need to ask yourself, I want to close this audit, because remember, for you to get maximum points in the portfolio, you need to do 2 closed loop audits. You need to ask yourself, this wait for change to cause effect, how long is it going to take, or how long am I going to be here? if you're going to be working in a hospital for over 2 years, you'll be a bit more relaxed because you say, well, I can do an audit that I can collect the data over a week or two, and then I can instigate some changes that will take 6 months to work, and then I can re-audit for another 6 months. So obviously, over sort of a 12-month period, you have your results. But if you're rotating from departments of after 4 months, you can't be doing that kind of an audit. So you need to be able to see the end from the beginning, because, or, if you have someone that works in the department that can be able to carry on the audit and make sure they put your name in the re-audit, then that's fine. That can equally work. So you need to obviously factor in where you are, what sort of environment you are in, before you're able to choose a good topic. And again, these are just things I highlighted from the internet, and you can read it up if you want. I probably wouldn't, but essentially highlight sort of why we're doing clinical audit in radiology, what's appropriate in terms of clinical audits, and where you can obviously get more information if you want to read up on clinical audits as well. Essentially, enhancing patient care, improving safety, departmental efficiency, professional development. Essentially, what we are actually looking at, or why most of us are here, is for this professional development. That's what will get you those maximum points in your portfolio, and that's what might be able to get you a training number in radiology or in any other specialty that you want to do as well. What are the types of audits? We talk about prospective versus retrospective audits. Like I said, people tend to confuse retrospective audits with research. They are not really the same, like we've alluded to. The prospective or retrospective audits, they're not mutually exclusive. Sometimes they actually coexist together. For example, you're trying to audit use of for foreign marker, for example, on a chest radiograph, for example, or use a foreign object marker in terms of foreign object detection in sort of normal plane radiography. Essentially, you can do a bit of a retrospective study over the last 3 months, check what the compliance is like in the hospital, and then when you do that, and then you can do a prospective after you've put in some action, or whether you've done whether you've implemented some changes, and then you can do a prospective as well. And then obviously another important distinction is between a process and an outcome audit. Essentially, a process audit will evaluate workflow and procedures. Essentially, for an example, if you're looking at consent in interventional radiology, you want to check whether everyone that comes in for any interventional radiology procedure have consent. Ideally, it should be 100%. That should be the target. So essentially, you're evaluating, workflow. You're evaluating the process. You want to make sure that every patient has consent. If they have informed consent, if they can't give informed consent, do they have a different sort of form of consent that covers for them? Example, from a relative or from someone that has a power of attorney, for example. Again, that's a process audit. And then if you're looking at an outcome audit, for example, if the RCR recommends that CTPAs for PE, that the diagnostic yield for PE should be about 15%. So you want to make sure that all the CTPAs that are requested in your hospital have at least a diagnostic yield of about 15%. So you're looking at an outcome audit there. You want to make sure that these resources are not being wasted, and obviously you want to make sure they're effective for patients' care. So the most important thing is that you need to find out what are the common radiology audit topics. This was the first recipe in radiology in terms of clinical audits, and it was over 100 recipes. Again, this has been modified a lot, and the newer version of this is what you see as Audit Live in the RCR website, which I'll come to in a bit. And again, it has lots of topics. Essentially, these are things that have been curated by members or fellows of the Royal College, and they give you sort of a topic, and they give you standards, and they give you methods, and you just have to just go ahead and just implement it in where you work, and you can come up with an audit that way. And this is a very nice sort of stratification of types of audits based on location. And I got this from Getting to Radiology website. Very good resource. Essentially, if you're in an emergency department, the type of audit you should be doing is different. If you're an emergency department, you don't want to go and be checking compliance of GPs with 2-week wait CT pancreas requests. You're not going to be able to do it because you don't work there, you don't know the challenges. How can you come up with an action plan? Who are you going to talk to? The consultants and your seniors will not be interested in the topic. So you need to be able to go and find specific topics that are based on where you work. If you're in the ward, there are ward-based audits. If you're in the community, there are community-based audits. And if you manage to get a radiology test a week, there are sort of audits that you can start on a test a week. There's audits that you can start on a Monday when you start a test a week. And essentially by Friday, when you're done with your test a week, you already have a closed loop audit at that time. So these are some things that you need to plan, ahead of time, to get done. So I think of clinical audit in this way. On the left or my right, I'm not sure. That's Haley Carruthers. She's a long distance runner, fantastic athlete. This was her in London Marathon 2019. And essentially, she's made it to this finish line. We could see that she's struggling a bit to cross that finish line. Again, you can perform audit that way, okay? But ideally, you need to perform an audit like Usain Bolt. You need to start it quick and finish it quick, and then move on to the next one. The more you spend time in an audit, the more it drags, the more you can't finish it, the more you're putting a lot of effort in, and you're not seeing optimal results. So essentially, you want to do audits like Usain Bolt, really. What are those key steps in conducting an audit? You want to find a supervisor or a mentor. I think this is the most important step in doing an audit. If you have someone that's interested in a topic, if you have a consultant or even a radiology trainee already, that is a senior trainee that is interested in a topic, that audit will finish one way or another because they need it for something. So these are the kind of audits that you should be doing, audits that are given to you by someone else, because those audits are the ones that you can finish quicker. Those are the audits that have bigger impact in the department. Those are the audits that tend to win awards. And typically, every radiology department I know in this country have an audit lead or clinical audit lead. They do have national audits lying around. They do have audit topics lying around that needs to be done, or an audit a trainee did and then they left it that needs finishing, and the audit department is looking for someone to finish it. Speaking to them is always a good way to know someone that is well versed in clinical audit, getting a good topic, and having something is already set out in stone that you can be able to do. I think this is the most important step in doing a clinical audit. I would not advise going to look for a topic yourself. However, obviously that can happen if you can't find someone that can help you to do it. You can find a topic and obviously find a supervisor or mentor as well and say, well, I have this topic, I want to do this audit. How can I go about doing this as well? Again, once you identify the audit topic, you have to set your objectives. You have to set your set your timeline. Define what you want to do. Define how long you want to do it for. Don't push it too hard. That's what some people tend to do, which can be a bit of a problem. And I did it a lot when I started doing audits, where I wasn't quite sure what I was doing. I felt I could do a data collection in one day, but I couldn't. Or essentially, you're going to try and make things a lot difficult for yourself. So the next thing obviously you need to do is you have to define your standards and your criteria. Again, you're looking for topics that have standards established. You're looking for topics that people know the standards, because that's the only way you can implement a good change. If people don't know the standards and you have to explain the standards to them, they don't actually know what to improve on. So essentially, you can't close the loop. Remember what we said. What you're looking for is you want to see something go from 10 to 20%. You want to see something go from 70 to 90%. You want to see something go from 70 to 95%. That's it. That's what you're trying to do. So you need to find standards and criteria that are measurable. And you need to find standards and criteria that people are aware of, so that when you're improving those changes, they can actually see it as well. And again, this is really, really important, especially if you're working in the NHS. You can't really do an audit without registering it with the audit department. I think it's a waste of time, and I think you're basically setting yourself up for failure, because the audit department is essentially your friend. They will chase you if you don't meet up with the timeline, which is obviously not a good thing. But if you're able to do a closed loop audit, you get a certificate from them. And that certificate is really important. That's really evidence that you need, and it will follow you forever wherever you go. And if you meet up the time, if you meet up with, and they can actually provide support and help for you if you're stuck, or if you need to speak to people to be able to get some changes done, especially if the audit lead feels that this is an audit that is really important for the department or for the hospital. So always try and get it registered. It's quick and easy to get registered, and always try and create a reasonable timeline as well. And then you collect and analyze your data. A simple Excel sheet is fine. And most time, if you speak to the audit department, there's always someone in the department that can do the initial data extraction for you and put the initial patient details that you need in an Excel file. All you have to do is to, go to the, if you're working in radiology, or if you have access to radiology system, the PAC system, for example, you can be able to pull, some of the data that you need, or if anywhere you're working from the electronic medical records, you can be able to pull the data that you need. And that's it. You compare your results with the standards and the criteria. Is it being met? Is it not being met? If it's not being met, what are the reasons why it's not being met? Do people need more education? Do staff need a bit of change in terms of how they see things? Just, that's it. You just have to formulate an action plan in terms of what you need to do. Do you need to present the audit somewhere to be able to, get people know that we're not meeting up these criteria? And that's it. Again, you give a bit of time, and then you re-audit to evaluate the impact of the changes. You see, it's not that difficult. I think we tend to make audits a lot difficult than it is, essentially. Obviously, if you have someone that can't give you a topic, what do? You have to go searching for a topic somewhere. I think there are two main big resources I always tell people. The first is, if you're thinking of something radiology related, I can almost guarantee you that someone has thought about it before, and you might be lucky and you see a template here in Audit Live, which is available for everyone in the RCR website. It's always good to search, check for an audit template. Even if your topic is slightly different, you can always modify it, because essentially in Audit Live, they give you a template. There's already a background, there's already a title, there's already methods, there's already standard set. Essentially, some of them even have the data collection sheet already. So the entire job is done for you. All you just have to do is to register the audit, collect your data, and that's it. You're done. And some of them equally have action plans in terms of what you need to do next as well. So Audit Life is really important, and you can find very nice topics there as well. Just a bit of highlights in terms of what defining on standards and criteria is. Essentially, some audits you don't have a specific standard or criteria. Again, you shouldn't be doing this alone. You should be speaking to someone, or there should be a superior or some senior, or a consultant that can be able to help you with this. You have to reference established guidelines. You have to determine whether this criteria is measurable. You have to make sure that the targets are achievable. You can't tell people if you request a CTPA, you have to make sure that 50% of the time, it's going to be positive for PE. That's not possible. That's not what the guidelines say, and it's not really measurable anyway. So essentially, that's not something people can fulfill. So essentially, you have to work within the confines of what established guidelines are. Anything you're doing outside of that is no longer an audit. Is almost being a research, essentially. And again, if you find the criteria, you have to ask yourself, what is specific in terms of my department? What does this department need? And how can I help this get better? Is this a hot topic that people are talking about? Obviously, if you're working in the NHS during COVID, literally most audits were about COVID and COVID and COVID and COVID. So essentially, you have to look at the context and see, what's a hot topic in where you work, what's a hot topic nationally, and then you can be able to make sure that you're choosing a topic that is, in reference to that. And then data analysis and collection, again, is quite straightforward. Just need a good Excel spreadsheet. Create a good Excel spreadsheet. Once you verify your audit and you're ready to go, try and collect at least 4 or 5, for example, 4 or 5 patients, and see whether is this spreadsheet intuitive? Is this pilot spreadsheet good? Does it need modification? You can ask someone to help you and just see whether this spreadsheet needs a bit of modification. But if you choose a good topic and you choose a good audit template, then you already know what needs to be in your spreadsheet. You don't have to go back and forth looking for more data as well. Obviously, you have to remember that data privacy is really important, especially if you work in the NHS and in the UK. So you have to be careful in terms of where do you store your data. Creating a good creating an account means people tend to obviously have an account in terms of the hospital system where they obviously keep their spreadsheet as well. And obviously, when you do your data collection analysis, you have to obviously formulate an action plan subsequently before you do your re-audit. And again, obviously from there is the audit loop. How have you identified the gaps? Have you identified areas of improvement? Have you assessed progress? Have you done your re-audit? What's your plan in terms of dissemination? Is there an upcoming conference that you can present it in? Is there an audit meeting that happens in the department regularly where you can present it in? Is there like a monthly meeting that happens that you can just ask a consultant for a 10-minute slot, a 15-minute slot to present your audit? These are the opportunities that you should be looking out for. Because once you do this, you've done the sort of part of your action plan and you're looking forward to do a re-audit to be able to close the loop. And remember, not all audits are positive audits. You can actually do a re-audit and the standards have dropped. It just simply means that there's something wrong that needs fixing. So you don't have to present audits where things improved only. You can also present audits where things are not improving or things are static. Again, it's about continuous improvement and identification of gaps and areas of improvement. What are some of the perils and pitfalls? Essentially, almost everyone has to do audits. And in terms of things that almost everyone has to do, actually, too many cooks spoils the broth. This creates a bit of a problem. And actually, I found this very interesting, actually. It was an audit that was auditing orthopedic audits. And I actually found out that, out of over 25 audits that were performed, only 20% of audits completed the audit cycle. And only 2 were against national standards. And 28%, almost a third of the audit was not based on any standards at all. So essentially, they were not really doing any audits. And you could look at just 30% of audits that are led by junior doctors, like most of us, actually resulted in implementation of the action plan. However, if it's a consultant-led audit, that number goes up to 75%. And actually, even nurse-led audits, the number is about 67%, which is over double of what we get as junior doctors. So it's really important that you involve these key stakeholders early. You need to find a reason why someone above you or someone that is working permanently on that particular ward or theater, for example, like a nurse or a radiographer, wants to get that audit done. Once you give them a reason why it needs to be done, then you know that you probably get, have an audit that you can finish. So essentially try and avoid projects without a clearly defined objective or an end game in sight. You need to ask yourself, this audit I'm doing, where am I going to present it? What's the plan? You need to know the end from the beginning. Again, you need to stop picking up low yield and high effort projects. You don't want to do an audit of 1,000 patients. That's a lot. That's a lot. And you might run into a lot of problems doing it. So you need to pick and choose. So it's not really quite wise to say yes to every project. If you see a good project that have a good team, that have a well-defined protocol, yes, get yourself in it. Because obviously you know that because of the team and sort of because of a well-defined pathway, most likely this will yield fruits. So it's going to be a high yield project. And essentially maybe what they will tell you to do is, just collect data for 50 patients and you get your name on the audit. And we're going to publish the audit anyway. So those are the things that you need to try and look out for as well. And it's not going to take you a lot of time for you to be able to do that. Again, like I said, lack of senior input is really important. And again, you need to know how to monitor improvement. You need to be able, like I said, you need to find a criteria that is measurable. What can you measure from beginning to end? This is why survey audits tend to work a lot, because once you give someone a survey before, you can survey something after. And if you do that, you already have some form of improvement, and you can obviously use that. So we have to look at some examples and some case studies. And just carrying on from the last slide, like I said, you need to be aware of the sort of audits that you're picking, because that will essentially mean that you can be able to finish or not. So I looked at some of the available resources, and this very nice article in ASIA about audit for radiology trainees is really cool, because even as radiology registrars, we have to do audits per year. You need one audit per year of training. And if you're doing a 5-year training program, so you need to have done 5 audits, by the end of your program. And most of the time, a lot of trainees are just doing it to be able to take it as part of their portfolio. They have other stress and other things they're dealing with, on calls, exams, and all that. And typically, why I tell people are applying for radiologists, if you find a radiology registrar that is doing an audit, you can always collaborate with them, because again, there's something in it for them. They need to finish audit for their ARCP. They need to get this audit done, for them to progress to the next year. And if you obviously help and get things done, or if you obviously take the lead and they're happy to be second author or third author, who cares? Essentially, they get satisfied because, the audit tick box is done for the year, and you get yourself a good audit that is probably going to be a closed loop from someone that is in the department and knows some of the key stakeholders as well. So I think, collaborating with radiology trainees where you work, because again, you're seeing them, you know how to contact them, you guys have the same system. That's a very, very good way of getting audits done. Again, these are some of the topics I picked up from Audit Live. Again, these are audits that if you know someone that has something to do with some of these topics, then it's an easy and a quick audit to do. And obviously, these are things that you should obviously be looking out for wherever you work. I'm just giving an example of this. Is one of the audits I did, and I did it with someone that actually got a radiology training number this year. Again, a similar thing, it's someone that came for a tester week, and we had a chat, and I said, well, I need to get an audit done, and you clearly need a project to get done as well for you to be able to apply for radiology as well. And essentially, we looked at this topic from Audit Live, appropriateness of CTP investigation for suspected PE. Essentially, it's a common topic. We knew it probably has been done before. We just have to find a good spin for it to be able to do the re-audit. And there's a very nice template for it already on Audit Live. So it was an easy one to register for already. So essentially, we looked at the background, which we know about. We looked at the cycle. So there are 3 standards. Essentially, we just want to make sure that, the referrals for CTPA studies are in line with sort of local protocol. And if you look at the hospital intranet system, there is a local protocol for requesting CTPA. And we want to make sure that the diagnostic code for CTPA is meeting published studies. Again, we didn't have to look for it because this audit Word document has given us all the numbers that we need, essentially. That, diagnostic code should be at least 15%, and an alternative diagnosis should be seen in at least sort of 50%. And the target for number 1 and 2 is about 100% each. And obviously, that's the target for number 3. And then what are the indicators? Is there an existing local protocol? Are there referring details available for patients that underwent CTPA, of course? And can you find the percentage of patients that have confirmed PE, alternative diagnosis, or no radiology, or no abnormal radiological diagnosis? Yes, of course, you can, because these things are available as patients report in the radiology system and in the hospital medical records as well. And then they actually tell you the data that you need to collect. It can be that easy. So you just need to collect this data and you have your audit done, essentially. And it actually suggests the number. So you can just collect 50, depending on the size of your department. So you can just collect 50 conservative patients. And then you actually suggested possible action plans that you need to do for you to be able to meet those targets as well. So once we picked up our topic, we realized that actually someone has done it before. And someone has presented it before, and actually it was a closed audit. So we're like, well, okay, so what's the point of doing this again if someone has done it before? Then I spoke to the audit lead in the department, and she said, well, this is old now. This was pre-COVID that the re-audit was done. She wants another audit to make sure that this compliance has not changed now, sort of 2 or 3 years down the line. So that's even a bigger blessing, because now we have a topic that's been done before. We have this topic, this has been presented in BIR before. One of the presenters there, Matt, is still a registrar here, so I know him very well. I have access to whatever they have done before. All I just simply need to do is to collect some more data, and that's it. I've done another re-audit. I've done another loop of the audit, essentially, and I can present those three sort of separate loops. And again, it forms a good, QI project or whatever. So, and then obviously, it helps me in terms of my progression as a registrar, and the person I was working with, essentially, he becomes the first author. He can present it as a national presentation. He gets full mark for that, and that's a full closed loop audit for him that he can get signed off by the audit lead of the department. Essentially, we get it all registered, like we said. Again, it's simple. In our hospital, they email you this form. When you just email them, you have to obviously, put in the title of the project. What's your time scale? Always put reasonable time scale. You don't want to put a very short time scale. You want to put a time scale that you can meet up with. So typically, I will say for some projects, I put 6 months, even if I know that actually I'm going to do the audit in about 2 weeks. I'll probably put 6 months. What you don't want is the audit department emailing you after 2 weeks to ask you how far, what's up. So you need to be able to give yourself that time. And again, it asks about what's the overall purpose of the audit. So essentially, it's a copy and paste. We know the purpose because the template has given us a purpose. We know the background because the audit template has given us a background. We know what the objectives are because the templates have given us an objective. We know what the standards or the guidelines are. We're not looking for anything. We know what these answers are. So we fill this out in 10, 15 minutes. And, this is just a slide from the presentation that we did in the department. Essentially, we identified the problem, which has been identified by someone before, and which was to compare the appropriateness of CTPA request against national guidance, and the method was to do a data collection of all CTPA requests in a time period. We wanted to collect key variables. We wanted to analyze the data. We want to compare it to national guidelines, identify areas of improvement. We want to make some changes. And the initial change that was made was introduction of mandatory requirements from clinicians. And essentially, just introducing this change, significantly improved, appropriateness of the request, essentially. And again, monitor. So essentially, this is where our current audit, came in, because essentially we were trying to make sure that whatever has been done before is still being followed, and is there still other areas of improvement as well. And then this is just a summary of what we did, essentially. So obviously, they did the October to November 2017. They looked at that was the initial audit, pilot audit. This was done like a year after. And then in June was the re-audit. And then obviously in May was this was the follow-up audit that we did subsequently. And again, that was presented in SRT as, he was the first presenter, and I'm sure he scored full marks for the audit presentation. Again, this was an audit that I did when I was a medical trainee. And again, it was when I was doing my ITU posting. Again, I was looking for something quick, nice, easy, a good hot topic. And essentially, I had a chat with one of the consultants, diabetes consultants, that used to come and review ITU patients during COVID. And essentially, it was more like, okay, I'm looking for a topic to do. So we said, okay, glycemic control in COVID-19 patient in ITU setting is a big problem. And actually, there's a new guideline which she wrote and asked, well, can I do this audit, essentially? So all I had to do was just find a consultant in ITU that was really nice, that can obviously help. And then we looked at just, 27 ICU patients with COVID that was treated with dexamethasone. And the good thing about this was I did the collection with my colleague we did the presentation in the ITU meeting. Again, ITU, they do meetings every day. So there was definitely an opportunity for me to present it. I wasn't looking for an opportunity to present it locally. So that was presented locally. And then I registered for the Diabetes UK meeting. That was in 2021. And if you register for the meeting to present your audit, all the audit abstracts go into diabetic medicine, which is their journal. So essentially, from doing this audit that was quite straightforward and simple to do, I managed to get an audit presentation for it. I managed to present it at a national sort of meeting as just a poster anyway. And obviously, there's a journal publication of the abstract somewhere, which obviously helps you in terms of your publication as well. So these are the things that you need to be looking out for. Again, I know not all of us work in the NHS and some of us are working from overseas. Can you perform a good clinical audit from overseas? The answer is yes. This is an audit that was performed in Wellington Hospital, Abuja, by my close friend, Kenne. And essentially was audit of management of traumatized brain injured patients in a surgical hospital. Again, this was a very nice audit, straightforward retrospective analysis of 24 patients. Again, very easy methodology. The consultants were keen to get these audits done, and he managed to, get good results out of it, essentially. And he led to an award. It was the best overseas trainee-led research or training in an ENT conference last year. And obviously, the guy that did the audits, the one in the middle. So yes, you can still do a good audit from overseas as well. And then I picked out some of the slides from RCR in terms of the winning audit posters as well. Essentially, these are posters. Some of the audit topics are not something that you think will win a prize, but what they tend to look at is what sort of impact does it have in terms of the process, in terms of patient outcomes, and what is the methodology. Again, this is a very, very, very simple thing that you can introduce and actually make huge impact for patient care. And most of the time, these audits are something that a consultant or a trainee have thought about, and you're involving consultants. And if you have a departmental input, it can actually have a bigger and a wider impact as well. I found this post really interesting as well, mainly because of the fact that the audit targets were locally agreed, and it was something that can easily be introduced, and it's something that can easily be sort of followed up because you're giving user feedback before and after. So you're expecting sort of a huge change, essentially. And again, like I said, people talk about data analysis. There's nothing difficult in doing this data analysis. All you have to do is to create some tables in Excel, and it gives you some very nice graphs, and you can do a presentation on it. Again, this was another fantastic audit from UCLH. Why I found this one interesting, again, this was a winner of the RCR e-poster competition in 2021, was it was trying to evaluate the service area in terms of acute reporting, and then obviously want to do workflow analysis. Essentially, in terms of the entire audit, the first cycle was performed in 9 days, and the second cycle was performed across 5 days, essentially. So in less than a month, you've done an audit that was able to win an RCR e-poster competition. I'm sure some other people spent more time doing audits, spend more time doing their own audits, but I'm sure you didn't win this award. So it's all about finding those low-hanging fruits, finding those good topics that can make a good change, people are interested in, and obviously working on it. Again, this is a very nice audit from last year. Again, this is more specific, and again, these are the kind of audits that people are looking for, and these are the kind of audits that a trainee will not think about. These are the kind of audits that typically will come from a consultant or a trainee can pick out from Audit Live, and then try and obviously but then you still need a huge consultant input in terms of actually trying to sort of get these audits over the line. Again, so in summary, you have to choose the right topic. You have to find a supervisor and mentor. You have to make sure you get your audit registered. And essentially, you have to find, are there low-hanging fruits? Is there something that someone wants to be finished and I can be a presenter? Is there something that someone wants help in terms of data collection? Is there something someone wants help with this and I can get my name on it, and I can help them with this and that. That way, you can tick one box and you can look forward to doing another one. And essentially, collaboration is key. You get more stuff done if you have a few people that are interested. Um, and if you want to read more open audits, which I don't think any of you want to do that. So thank you. That's the end. And I will end the show.
Thank you very much, Dr. Egwe, for the presentation. It's been very, very educative. We'll be opening the lines for questions. Please, if you have any questions that have not been typed into the chat box, please can you do that now? We have some questions that are already in there. Should I read them out, or would you be able to see them?
You can read them out, or I can have a look as well, just to make sure we.
Okay,
Yeah.
I guess the first one has been answered. There was a question about where can we find these audits. I think you've been able to elaborate very, very much on that. The Audit Live discussion with trainees and consultants.
Yes.
There's also a question of for IMGs, will audits performed locally be recognized in the UK?
Is the audit performed locally, like is it like back home in Nigeria or somewhere else or another
Back home
country?
in Africa, anywhere. Yeah.
I mean, it is recognized. Like I said, someone did an audit overseas and you won an award here in the UK. So it can be done. All you just have to make sure is that you're involving all the right stakeholders. You want to make sure that a consultant where you work in that particular hospital is going to give you a reference or some form of letter that you did this audit, and always try and present it somewhere and try and get a certificate for doing that presentation. And that's it. That's all you need. You just need to have a documented evidence. Like in all things that you do, you need to just have a way of documenting it. I mean, if you're working in the NHS, then it's very easy for you to document it because most of the time they already have templates. They already have audit certificates that you can get from your department, or you can present in different conferences all over the country. That can get you can get a presentation from. But sometimes it's very difficult to get that abroad. But you need to have that in mind before you do an audit. You have to have that. Okay, I need to get a certificate for this. And obviously you need to be able to have that in mind so that when you're pursuing the project, you're doing it to make sure that whoever you're doing the project with or whichever institution you work will be able to give you some form of a certificate for it, because that's what you need for your portfolio.
Yeah, I think that's very important, especially for those of us who are still like very early in our medical career, final year medical students, or just like early junior doctors. We're able to start getting this proof of audit presentation or participation in audit process early enough. Yeah, prior to
something that we didn't do back home, especially the fact that we did quite a lot of similar projects. We did stuff, like that. But you just do it and you move on when you're a house officer, and you didn't really document these things, and they play a huge role here, because obviously the good thing about the NHS is that they tend to recognize things from abroad, but you need to have an evidence that is verifiable. You need to have evidence that it has been done.
Okay, so there's another question from me who says the criteria says 2 audits that have changed practice. Does this mean 4 cycles, 2 cycles for each audit, or do we just need 1 audit then a re-audit to check for change practice?
A very, very good question. I personally don't think that it is actually asking you to do 4 cycles. Or it doesn't necessarily mean that you have to be the person that have actually done the 4 cycles. For example, if someone else did an audit and they did the first cycle and you're just doing the re-audit, right? That's one audit. That's a closed loop audit. And actually, you led that audit because you led to the fact that the audit got finished. and it's closed loop. So essentially, you might just do one cycle of an audit that have been done before. You manage to get one closed loop audit. And again, it can mean 4 cycles because you might start an audit and finish an audit. That's one, so that's 2 cycles. You start another audit and do another audit. That's 2. But again, it depends on the context, which is why I always talk about the fact that you need to involve the right stakeholders if you need to get these things done, because they can take a bit of time. It requires a bit of an effort to do, but if you involve the right people, it can actually become easy and very streamlined. You can find projects that have been done before that just need someone to close the loop, and that's one audit, done. Or you can obviously start a new project afresh and pick something that you can easily do the data collection in a few hours, and that's your first cycle done. And then you can find a way to present it and do the re-audit, which might take a bit of more time to do, and that's your second cycle done. I hope that. And again, changing practice sounds like a big term. It's not. Changing practice, like I said, simply means that you're showing that numbers are moving on a graph. You're showing that 20% is now 30%. You're showing that 40% is now 50%. You're showing that 50 patients are being seen instead of 30. That's essentially what changing practice means. Changing practice doesn't mean that the CEO of the hospital have to come and shake your hands based on the audit that you did. Changing practice can actually mean something very, very simple. So it's just don't think about changing practice as something really, really difficult.
Okay, before the last question, I just want to say we'll be putting the feedback link shortly in the chat box. So those of us we welcome feedback from every person who has attended this program. The next question says, can you do a radiology department that's unrelated to the department you work in?
Yes, example, if one works in ONG, absolutely, 100%. You can definitely do a radiology. I mean, even off the top of my head, you can do a topic on, adequacy of. I mean, there's something probably on. There's I don't know what I can think of the top of my head in terms of ORADs. If you think about ORADs, which means radiology reporting system for ovarian cyst or ovarian tumors, for example, you can easily do that, and all you just have to do is to speak to one of the sonographers or speak to your radiology department and say you're working in ops and gynae and you're keen on doing sort of an audit that is related to sort of obstetrics or gynecology. There are lots of audits that you could do that are radiology related. And remember, if you do an audit that is not radiology related and you can present it in a conference, you can still claim points for it as well. So that's still something that you can still do as well. But in terms of being in ops and gynae, again, there are loads and loads of audits related to radiology that you can do in ops and gynae. I'm 100% sure of it, and I'm sure that if you obviously even go to Audit Life now, just I can't think of any example on the top of my head, there will certainly be a lot of topics that you can find. Again, you need to find something that is doable. You need to find something that is a problem that you think is a problem in your department. You need to run it by someone first to make sure that they agree with you that actually this can be done before you go about doing it as well. And it's always important that if you actually just find a way to speak to someone in the radiology department, I'm sure that they will have they'll be more than welcome to either find a topic for you or guide you in terms of how to be able to do an audit that is probably related to where you work.
There's one more question. I'd assume that we don't have any more questions. If we have, please just make sure you put it in the next 2 to 3 minutes so we can address them on time. The next question is from Ikimi, who says, would an audit done on a respiratory ward count as a radiology audit if it involves data analysis from PACS? So that's the picture academic communication.
Yeah, if you're looking at chest X-rays, yes, it's a radiology audit as far as I'm concerned. If you're If you're looking at any form of radiology investigation, yes, it's a radiology audit.
All right.
Yeah, it's a radiology audit. Ultrasound guided acetic types of drain on the gastro, yes, that's still definitely a radiology audit as well, because you know they still involve some form of imaging, to be honest. And again, it depends on how you want to spin it. The most important thing is that you're looking at, is this improving patient outcomes? Is this improving the process? And can you demonstrate any change at all from it? Once you can be able to show that, that's it. And can you find a way to present it somewhere? And can someone give you a certificate for it? That's definitely will count as a radiology audit. Ultrasound guided, in fact, ultrasound guided procedures on the ward can actually win an award if you actually design it properly, because sometimes it can be a big problem in terms of big hospitals that have a big interventional radiology department, because they tend to get these ultrasound guided acetic types of drains. But if you can demonstrate that people on the ward can do it with imaging guidance without having to overload the interventional radiology department, you're already thinking about yourself winning an award with this poster. Like I said, you just need to have to find a way to, to find a template. Someone somewhere has probably done this before. You just need to find that audit. Search the internet properly, search previous conferences. There's probably a poster somewhere on it, that you can find. And then you can be able to plan your audit around it, and then find action plans that are doable. You don't want to do things that are too difficult for you to do, because that's when you run into trouble. You have to find something that, like I said, you have to know the end from the beginning, and then that way you can be able to find a way to be able to present it somewhere and to get a certificate for it or something.
All right. It seems we don't have any more questions on the presentation. So we have a group for members of the Radiology Interest Group Africa. If you're there'll be a link posted very shortly in the chat box if you're interested in joining to be a member. We're working to have access to multiple trainees that we can work with, especially get guidance from, as they are very much more experienced in engaging in audit. A number of us have done, but the trainees have more experience with it, and we have more access. So we are working to create sort of like a collaborative space where we can sort of get more experiences, mentor ourselves, support ourselves towards engaging in this project. I saw someone ask them for Dr. Emeka's LinkedIn. He is on LinkedIn. I just checked.
It's very good. I have a lot happening on LinkedIn, to be honest. But
yeah,
just my name on LinkedIn, to be honest.
Yeah, so you can connect with him too on the group page also, and also that's the WhatsApp page we have for the members. And yeah, you can reach out to him on LinkedIn also. So we in the absence of any other questions, we'd like to say a very big thank you to Dr. Igwe, who's been very supportive towards the goals of this interest group, and for taking the time to prepare a slide and teach. Make a presentation and also answer the questions we have. It's been very helpful and insightful, and sort of in a way you've been able to demystify the process. We're no longer, I don't see it anymore as a process of the big thing. It's just finding something that works, a good topic, good supervisors, and trying not to bite more than you can chew, and trying to do it. Yeah, do like things that would definitely impacts the clinical practice positively wherever we are in the world, in the UK and also elsewhere. Following this presentation, we'll have just a short announcement from the academic lead about our future programs. So Dr. Fumi would be helping us with that.
Hello, everyone. Hello.
We can hear you.
Oh, great. Thank you. Thank you very much, Dr. Igwe. I really loved your presentation. Thank you, everyone, for joining our very first event. I hope we still see more of you. So coming up next, we hope to have like a research bootcamp, if I can put it that way, where we're trying to put up a structure to help with our portfolio. one of the things that we need to get is publications. So we'd like you guys to register to be members, but we are trying to put up a team that would help us to get a publication, or either as a first author or you collaborate with a friend, just to at least get the points for publications as well. So be on the lookout for that. Thank you.
We'll be drawing this event to a close shortly. So we will send a link. There's been a link in the chat box for feedback. If you have any questions or you have any inquiries, our contact address are on the descriptor for this event. But our email is radiologyinterestgroupafrica@gmail.com. You can always send us a message and we'll respond to it as soon as we're able. We also I've also pasted a link to register as a member if you're interested in our other programs. We like the educational lead explained, we're trying to organize a program where that's sort of like a support group, and we get people who have engaged in multiple research, who can guide us, teach us through some research methods. For those who want to like publish papers or want to engage more in the process of research, we'll be able to like have like a support group over the next 3 to 4 months, and we're looking to start this by next month. So it will be helpful if you join on time and indicate your interest, so we can plan appropriately towards it. I'd like to say a big thank you for everyone who's been a part of it, and the team was helped with organizing this. Doing a lot in the background to ensure that this program is this event was a success. So just appreciate everyone who was able to turn out and the attendees. Thank you very much, and have a nice evening.